Yeah, it causes gut damage, it causes liver damage, and reaches your circulation. So when enough gets through your damaged gut eventually, and enough gets through your liver filtering processes, then it can actually cause damage to the blood-brain barrier. It changes your neurotransmitters in your brain. So we're now associating sort of endotoxins with anxiety, depression, cognitive decline, short-term brain fog, long-term Alzheimer's disease.
Welcome to the Radical Health Rebel podcast. I'm your host, Lee Brandon. This work started for me several decades ago when I started to see the impact I could make on people, helping them to identify the root cause of their health problems that no doctor could figure out, including serious back, knee, shoulder and neck injuries, acne and eczema issues, severe gut health problems, even helping couples get pregnant after several IVF treatments had failed. And it really moves me to be able to help people in this way. And that is why I do what I do and why we have this show. Welcome to this week's episode of the Radical Health Rebel podcast. I had the pleasure of interviewing Dr. Jason Hawrelak, a renowned researcher, educator, and naturopath with a wealth of knowledge and over 2 decades of clinical experience. With a PhD focused on probiotics, prebiotics, and herbal medicines for gut health, Jason has been teaching audiences worldwide on microbiota modification and gastrointestinal health. In this episode, we dive into the topic of small intestinal bacterial overgrowth, otherwise known as SIBO, a condition that affects many individuals today. After taking one of Jason's courses on SIBO a few years ago, I've been able to apply his teachings to help those suffering from this debilitating condition who had previously struggled to find relief through traditional medical avenues. Stay tuned for an insightful discussion with Dr. Jason Hawrelak as we discuss the symptoms of SIBO, its connections to other health issues, and how to effectively manage and treat this condition. Jason Hawrelak, welcome to the Radical Health Rebel podcast. Thanks for coming on the show.
Hey, it's lovely to be here. Thanks for the invitation.
Yeah, it's a real pleasure to have you on. As I kind of alluded to in our communications before, I took your course in small intestinal bacterial overgrowth some years ago that was provided via In Vivo Healthcare. And it was just such a fantastic course. And it's massively helped my own practice. And, the amount of clients that I've helped based on your work is pretty incredible. And I'm sure if they knew where I got a lot of my information from, they would be thanking you for the help that I've been able to impart on them. So, I just want to say from my own perspective, thank you so much for your work. It's absolutely fantastic.
Well, thank you. It's lovely to hear that. It's amazing hearing feedback like that, because that's what we wish for. Is that you can help other practitioners with their patients and get better results. That's kind of what I'm aiming for. So when I hear feedback like that, I get very, very pleased indeed.
Yeah, absolutely. So, Jason, to kick things off, could you share with the audience your educational and professional background and how small intestinal bacterial overgrowth became a subject that interested you?
Yeah. Well, gosh, I'm not sure where to start. That one, I can go way back to we spoke just before recording started about, I'm originally from Canada, and I came over to visit Australia as a backpacker on my way around the world. But I arrived in a immensely health conscious part of Australia back in the early 90s, a place called Byron Bay. And it just really went from eating horrible junk food, typical sort of standard American type diet, although I was Canadian, but same kind of fare, to eating immensely healthy. And just the improvement in my health was just amazing from that point. That really got me interested in following through with later studying naturopathy. So I ended up studying naturopathy in the mid 90s, and then when I was finishing up my naturopathy course at the University, Southern Cross University here in Australia, I had a discussion with one of my lecturers about doing postgraduate studies in the area of dysbiosis, so altered gut microbiota. And this was back in 99 when I had these initial discussions. And he's like, yeah, we can do research project. Well, how about we do a study in irritable bowel syndrome? Because that was essentially at that point, like now we see dysbiosis being associated with Parkinson's and Alzheimer's and heart disease and cancers. That was not the case. 24 years ago, it was like there was dysbiosis associated with ulcerative colitis, Crohn's, and irritable bowel syndrome, and not too much else had been researched up to that point. So we chose IBS as like the poster child of a disease associated with gut dysbiosis. And then I ran my first clinical trial using prebiotics, probiotics, and herbs to modify the microbiome in IBS patients in 2000 from my honors degree. And then I followed that up with my PhD, which is doing more research on how we could alter the microbiome in positive ways using those tools of prebiotics, probiotics, and herbs to alter the microbiome. And then obviously, in the mid 2000s, there became sort of all of a sudden this thing called SIBO, small intestinal bacterial overgrowth, started getting some airplay. That was generally before that seemed to be an immensely rare condition that would occur in some people after abdominal surgery, where you had bits of your small bowel removed, bits of your colon removed, and all of a sudden you'd have because of the dysfunction, motility that resulted from that, you'd have it build up with bacteria, and these people, often kids, would get very sick and were hospitalized, etc. And that's kind of the view of SIBO up until probably the early 2000s, when Dr. Pimentel started publishing more work around this concept that it actually may be a significant driver of the disease we call irritable bowel syndrome. So I think because of my PhD was in IBS and colonic dysbiosis, so in the large bowel, I obviously became quite interested in following this sort of information that was flowing out about stuff happening in the small bowel, which wasn't really widely discussed much at all, and partly because we just could not really see what was there in the same way as sampling poo. That small bowel was kind of like an area of ignorance or unknown, because we just really didn't know what microbes are there, what proportion, et cetera, when people were really unwell, and we could send some scopes down there. But again, that whole, that's really blown up in terms of the amount of research studies published looking at what's normal, what's abnormal in the small bowel microbiome, and also linking SIBO to a range of other conditions besides just IBS too. So that's been an interesting thing to observe over the last 15 years too, for that matter, 20 years now actually.
So what year did you complete your PhD?
Well, we had a couple delays in that one. So in terms of clinical trials, don't always go according to plan. We had some funding issues for we're going to do a large scale randomized double-blind placebo-controlled trial, and we had funding lined up within. Didn't come through in the end. So that's like an extra year to your PhD project when things like that fall apart that are outside your control. So I think it was 2006 when I actually finished my PhD.
Okay, so that's 18 years ago. What have you been up to in the last 18 years?
I've tried to maintain, even that whole time that I was in my honors and my PhD, I was also a clinician. Yeah, and for me, it was important that, one, it was part of my training, and two, I really liked seeing patients, and three, I think it helps you as a researcher to bring a different viewpoint when you're working with patients and interacting with patients. You can see what works, what doesn't, what things are like in real life. And I experienced that firsthand in my first clinical trial that I did in my IBS patients back in 2000, where I gave them like mass loads of prebiotic compounds, because the research was like, this is the dose you give for a prebiotic effect. And then the patients were getting like, severe distension and bloating and farting like crazy. And you realize, okay, real life is, I want to start with a low dose and slowly build up, or, there's different ways of doing it that you kind of learn from actually having interaction with real patients, of how to do things outside research settings. So I think for me, it's always been important to maintain clinical practice as well as doing research. And I've maintained that up until the present. And I have also been teaching either soon-to-be clinicians or clinicians, probably from, I think I first started doing some, teaching at the Southern Cross University naturopathy course back in 2000, just doing bits and pieces, but that sort of grew from there. So, for me, it's the three prongs that give me fulfillment and joy are teaching clinicians about, gut health and microbiome health and seeing patients and doing research in those areas.
Yeah, I'm guessing you're like me. You're absolutely fascinated by the gut and the gut microbiome. To me, it's such an exciting subject, and I feel that the more I learn, the more I realize I don't know, and the more that I suppose, as a community, we realize we probably know very little about the gut microbiome, even though we've learned so much. There's probably, I sometimes call it the final frontier, because there's probably so much more that we don't know.
No, listen, it's true. I mean, I also think that this has been like 24 plus years I've been delving into it. And I think back to when I was, writing my, honors thesis and having to go through all the microbiome literature at that point we called microflora. If I could read all the papers from the 60s and 70s and 80s leading up to that point, because there wasn't that much comparatively done, and then it's what's occurred in the last 20 years. It's been mind-blowing in terms of when we changed technologies from, culturing the microbiome to DNA-based technology. It's just the research has gone absolutely crazy since then. So while I agree that there's tons more to learn, I also know that there's actually quite a bit we know now, and have learned over the last 50 years. Yeah, and I think thankfully, perhaps because I've been doing this for over 24 years, it's been my main passion and job in some respects of keeping up to date with microbiome research. I feel like we know quite a bit already, but I'm also aware that I'm looking at someone's microbiome report. There's a bunch of species we have no idea what they do. Yeah. On that report. Like there's some that I can go, okay, yeah, that's clearly pathogenic. These are clearly beneficial in usual circumstances. And these ones are what we call pathobionts, which are ones that cause harm when in excess amounts, or I'd even argue in insufficient amounts, but are great for us when they're in the right zone. So there's a bunch of bacteria we can categorize into those three sort of levels or areas. But then there's a whole bunch on that test that we have no idea currently what they do, what role they play, what percentage they should be, et cetera, too. So that is an exciting area that I'm going, okay, well, every year we learn a bit more. Like, even this past year, I've been, teaching, creating new courses for around the microbiome, advanced microbiome manipulation, delving into the research a bit more on polyphenol transformers. And you're like, oh gosh, it's a new bacteria that have just recently been named that we know are now key players for polyphenol transformations that I'm now looking for in stool tests that I wasn't looking for 12 months ago. So it is that's an exciting thing too, I reckon. So you're constantly learning and looking forward to do it. And I think I'm just also so lucky that I chose a topic that I'm absolutely passionate about for my PhD, and then that flowed on from there, because I know people who did not. He just chose whatever topic was available or something that was easy or something, but didn't give them excitement for their PhD topic, and then they're happy to leave it behind and never look at it again. Whereas for me, it's like still super excited to look at the new research papers come out. Still super excited to looking at my patients' microbiome reports to go, okay, oh my God, what's that looking like? How's it changed from last time? How does that fit in with their current symptoms or the improvements that we've seen, et cetera?
Yeah, I find something quite interesting. There's quite a move. I guess it's probably to some degree a fad, but there's quite a move towards, carnivore and, high animal-based diets and things like that. And, from my understanding, if you look at the research, it's like, well, that should be a disaster for the microbiome. But then you see people completely reversing autoimmune conditions and things like that by going on those kind of diets. And I'm just really curious on, kind of how does that work if that's going completely against the research? It's not something I necessarily wanted to discuss today, but if you could maybe quickly give your view on what might be going on there.
Yeah, I mean, and this is a bit hard because when I see people that have done carnivore, people that are immensely unwell and worse from doing carnivore, it's like I haven't seen any patients do carnivore and get better from it. Right. Maybe I had one. Out of my 20 years of practice. But, again, I concur that I've got a bit of a skewed thing, because if they're going great, they're not necessarily going to come to see me as a clinician. And I mean, obviously for some people, it's all the horrible food chemicals that people are consuming that I think that might be contributing to their disease, and their sort of gut damage, for example. For some people maybe, had celiac disease they didn't know, so they also stop eating gluten, and their gut symptoms and other symptoms get better from that process. There's things we can conjecturize around of how some people might improve on that, despite the fact that there are major concerns from microbiome perspective. And I think that's one thing that I often find challenging, is that people are often promoting like a carnivore type approach aren't recognizing that you are, like a good portion of you are microbes. It's like it's sort of that old physiology that we're humans that has some bacteria, and bacteria don't really matter too much, is the old idea, and that they're kind of fitting in that pattern for the most part. I'm sure there's some exceptions to that too, but for the people I've seen, if that's what they're thinking about, they're not thinking about gut bacteria at all in their way of viewing the world. But we know now, beyond any doubt, that the microbiota is immensely important for human health. And we also know from, research and just from what we know about microbes is that we generally see blooms of problematic species when people go on that kind of dietary approach, and massive reductions in beneficial species when they go on that dietary approach too. And it's not to say that in the short term there may not be significant improvements in symptoms, because I'm sure, listen, if you've got bloating and distension, are core things that are causing you, horrible symptoms and pain, and you essentially go on a diet that limits your intestinal fermentation dramatically. Is the bloating and distension going to go away? Yeah, it is. It's going to feel better in the short term. Yeah, you will. The challenge there is that the change in microbiome dynamics in terms of starving your butyrate producing species, and increasing levels of hydrogen sulfide gas producers, which are two of the broad sort of results we tend to see from such dietary protocols, end up causing inflammation and colonic harm and worsening symptoms over the long term. And those are the people I see that have tried this for a period of time, and they're far worse off now than what they were before they did that dietary approach. And it's really hard to get the microbiome back because they've starved off a lot of the good bacteria if they did it for longer periods of time. And their degree of visceral hypersensitivity in these patients is immense. And we know that hydrogen sulfide gas causes visceral hypersensitivity. And when you're essentially eating a dietary protocol that feeds your hydrogen sulfide gas producers as much food as they want, and you're not feeding any butyrate producers, you end up in a situation where your colonic sites become very hypersensitive to gas production, to movement in the gut, to et cetera. So that when you try to bring food, fiber back in at a later time point, and there's some gas being produced, they experience quite severe symptoms. So you see these patterns going, oh, well, I would do this and my symptoms are at this level, but I tried to bring some plant food back in and boom, I get these gut symptoms back again. And it's because you're essentially exacerbated the degree of visceral hypersensitivity or chronic inflammation in those patients. So it ends up being a very challenging cycle to get people out of, sadly.
Yeah, that's really interesting. And I guess, when you look at, I suppose you can call them isms, right? Carnivoreism, veganism. Certainly what I've seen is when people go to either extreme, they might feel better for a period of time, and then there comes a point where they actually start to think, okay, I need to kind of go back the other way if I'm going to feel better. And I guess it comes back to two things: individuality and to some degree whatever balance is for that person, right? I think most human beings are somewhere between those two extremes. And when you go to one or the other, it's going to cause problems, right?
I do have some concerns around, strict vegan diets too, in terms of potential negative health outcomes, but not so much from microbiome perspective. And obviously that's the way that I kind of view the world, is mostly through microbiome perspective. And I've got far more concerns around carnivore dietary protocols than the vegan. I know the vegan, you can get B12 deficiency, and zinc is really challenging to achieve. Totally get that, no doubt. But, you are able to nurture wide diversity of healthy microbes through that kind of dietary approach. Or for me, it's predominantly plant-based. It's like, I don't really care. If you have fish and meat a couple times a week, it's not a concern from a microbiome perspective. In fact, for good sources of iron or good sources of zinc, there's omega-3 fats, which is good rationale for having those sort of smaller inclusions. But to me, it's around trying to nurture the widest diversity of health-promoting species in the gut possible, which is eating mostly plants. And whole foods too, because I think that's a thing too.
Yeah.
I remember the first vegan I ever met lived off of coffee, hot chips, and twisties and cigarettes. They were vegan because they didn't want to kill animals, which I can understand, but they had no idea about how doing it well. So just because someone has a vegan, it can still be an absolute rubbish diet full of rubbishy processed foods versus someone who's actually eating, whole food type food choices.
Yeah. Just to go back a little bit, if you were to explain what SIBO is to someone that had never heard of it, how would you describe it to those kind of people? When 35-year-old Amanda first scheduled to see me, she'd been suffering for 19 years from severe IBS, diarrhea, and fecal incontinence, along with abdominal pain and bloating. Her condition had not only made life uncomfortable for Amanda, but very inconvenient, as she had to walk 2 hours to work every day along a route that had public toilets, and she'd never been on holiday as an adult because of her condition. The only advice that several doctors and specialists had given Amanda was to take Imodium, and when she first saw me, she was taking 5 Imodium a day and wasn't getting any better. To help Amanda, I ran tests to find out what foods were right for her metabolic type, to see which foods she was sensitive to, and to assess her gut microbiome. Tests showed that Amanda had several food sensitivities and a parasite infection. Over the coming weeks, I coached Amanda to eat right of her type and to replace the foods she was sensitive to and a protocol to deal with her parasite infection. And after 3 months, Amanda was IBS free, and she also reported her skin was much improved and she had lost weight. And she booked a holiday for her and her husband to New York, as they'd never been on a proper honeymoon because of her IBS. And if you're suffering like Amanda was, and you want to get to the root cause of your problem, you can arrange a consultation with me at www.bodycheck.co.uk. And if we're a good fit, I could help you achieve the same kind of results as Amanda. Now, back to the podcast.
Yeah, I mean, I think it's SIBO, small intestinal bacterial overgrowth. So in some ways, the name kind of gives it away what we're talking about, but it's an overgrowth of bacteria in the small bowel. And if you go back to some of the earlier popular ideas around SIBO or blogosphere ideas, were like, oh, the small bowel should be sterile, and it's just, any bacteria are overgrowing. I think that's been tossed out in both ways. One is we've long known that the small bowel is not supposed to be sterile. It's supposed to have smaller numbers of microbes. It does, versus the colon, but never sterile. And two, this idea that it's just any bacteria growing, including good bugs, could be growing in there and causing harm. It's kind of been tossed out too, because what we're tending to see now with research is actually there is in patients with SIBO, we tend to be overgrowth of pathogenic bacteria and a lack of diversity in that small bowel ecosystem. So it is more of a monoculture type ecosystem with bad bacteria growing there, versus just overgrowth of any potentially and even some beneficial bacteria. So that's been a shift in there too. But that's just a bit of an aside. But so essentially, when the bacteria are growing in the small bowel, they have access to your nutrients, your food, before you necessarily have a chance to absorb it. Yeah, so they can actually steal some nutrition, and I've seen this commonly where patients are chronically iron deficient because the microbes are eating the iron before it gets absorbed. But they're also producing intestinal gas in the small bowel in larger quantities than what typically would be the case. Yeah, and that can cause bloating and distension are very key symptoms of classic symptoms of SIBO. But the other issue too is that some microbes, when overgrown, like E. coli or Escherichia, other species, or Klebsiella, for example, also cause gut damage or leaky gut. And they're also, when they're growing and dying, releasing endotoxin, because gram-negative bacteria all grow this stuff called endotoxin, just like we grow hair, we grow nails, they grow endotoxin. And it just happens that their endotoxin is immensely inflammatory. Yeah, it causes gut damage, it causes liver damage, and reaches your circulation. So when it gets through your damaged gut eventually, and enough gets through your liver filtering processes, then it can actually cause damage to the blood-brain barrier. It changes your neurotransmitters in your brain. So we're now associating sort of endotoxins with anxiety, depression, cognitive decline, short-term brain fog, long-term Alzheimer's disease. Yeah. So there's a myriad of other symptoms people can get besides just bloating and distension, and changes in bowel patterns. You can get fatigue, because endotoxins are also mitochondrial poisons. You can get anxiety, you can get depression, you can get and the very classic brain fog from that too, because you are getting brain inflammation from these endotoxins. You can get metabolic dysfunction because endotoxins impact blood sugar regulation and cause inflammation everywhere in your system. And if you have a weak area where you're kind of prone to having inflammation, all that endotoxins floating around will generally cause inflammation in that weak area for you, which can be different. For some people, might be thyroid. For other people, it might be their knee pain might flare up. So it's an interesting condition that I think is a driver of a lot of symptoms that go beyond the gut. Yeah, because I think originally, again, people thought, okay, it's just bloating and distension, which can be severe and life changer that can be relatively mild depending on the person. But there are other sort of body-wide symptoms that you can get from having SIBO that are problematic short-term and certainly long-term. Like we know now that you look at something like Alzheimer's disease, where when they've done autopsies of people with Alzheimer's versus healthy controls who died at similar age and look at levels of endotoxins in their brain, people with Alzheimer's have between 2 and 20 times more endotoxin in their brain, because of, and that's coming from the gut. So definitely do not want, these sort of endotoxin releasing bacteria in our gut in large amounts, and certainly not associated with gut leakiness, which is what we tend to find in SIBO.
Yeah, I think fibromyalgia is another one, isn't it, that's been linked to SIBO?
It has been, yeah. And I mean, one of my PhD students is on a brilliant research project trying to delve into that, and she's writing up a thesis right now. So we'll have to wait to see exactly what came out from. We did breath testing and microbiome assessments of the gut and oral microbiome assessments for a bunch of patient cohort with chronic fatigue syndrome to see if we can, fibromyalgia, to see if we can actually see patterns there. And we'll have to wait until some more stuff is published around that. But it's perhaps not as key driver of fibromyalgia as we once thought, I would say, based on preliminary look at the data.
Interesting. So you just mentioned Alzheimer's there. And obviously we know about the gut-brain axis. Have you looked into any link with SIBO and autism, for instance?
I think there's at least one study making a connection there. And as someone who treats and sees a lot of patients with autism, SIBO is not uncommon in that cohort for sure. Not everybody, but it's not uncommon. And particularly I would say the methane variant is more common. And when we have a overgrowth of methane producing microbes in the gut, we tend to have a slowing of transit time. And that slowing of transit time can manifest in obvious ways like constipation. And that's, quite common amongst the ASD community. Not everyone, again, but there's a number that do. And in that population that is constipated, having an overgrowth of methane producing microbes in the gut is immensely common. And when we're able to address that, then bowel pattern improves, transit time speeds up, and not surprisingly, I would argue that other symptoms improve, like awareness or learning capacity, speech, etc., that improve from that process too.
Yeah, I don't know if you're familiar with. I'm trying to remember the name of the movie. I had the producer on the show. Invisible Extinction, it's called.
No.
And it's a movie about the gut microbiome and how, the use of things like antibiotics are really problematic, and how actually it could be that, we're leading down the road of actually having a lot of our microbes become extinct in the human body, which, there's only one way that ends if that continues, right?
It's really scary. I mean, if you look at some of the data around antibiotic usage, like there's a study published in Gut a couple of years ago where one course of an IV antibiotic, I think ceftriaxone, resulted in 9 species going extinct. 9 species from just that one use. And you think of the people who tend to see their in that sort of typical medical model might go and get a course of antibiotics once a year or twice a year. It's not uncommon in that situation because they're still being, we know, prescribed way over the top for viral infections in Western medical systems. So people are essentially, every single generation of Westerners is just having a less and less diverse ecosystem. That is clear. And that's even just looking from the medication perspective, let alone the typical Western diet, which has negative impacts on the microbiome, let alone increased rates of C-section birth and formula feeding, both of which have negative impacts on microbiome composition too. So we have this sort of perfect storm of C-sections, very high rates of C-sections, high rates of formula feeding, and then lots of antibiotic use as a kid, and you end up with these really narrowing microbe ecosystem. And then that gets passed on. You can only pass on to the next generation what we have. Yeah. So if your ecosystem's already been majorly damaged from early childhood factors that were nothing outside your control, you can only pass on those microbes to the next generation. They only have that number, and someone who does tons of microbiome assessment with patients I've seen this firsthand. I've had some patients who show up with 12. Seriously, the lowest I've seen on a test is 12 species of bacteria in someone's gut. The highest I've seen is like 450 to get some sort of spectrum about how that actually differs in different patient cohorts. And that the 450 was someone that had, grew up in rural, non-Western environments. So their ecosystem was far more intact, whereas the one with 12 had taken a lot of antibiotics in their life.
Yeah, I'm going to tell you something that's probably going to horrify you. I suffered with acne from age 13, and I took antibiotics for 18 years.
Yeah. Yeah, and your story is probably not that uncommon among Western nations. And listen, I can say too that I was in that sort of the Western medical model childhood where, formula fed, junk food predominantly fed. I would argue too, a processed food, and antibiotic courses, probably a couple at least a year, most years when I was a kid. And I look at my, and yes, since I was 18 and discovered how to be healthy, things are completely different that way. But there was a lot of damage done in those early windows in terms of my diversity of my ecosystem. Like my ecosystem is not nearly as rich in microbial species as it should be because of all that damage that was done in my early life.
Yeah. And just getting back to the movie Invisible Extinction, the reason I thought of that was because in the movie, and I know we're talking about the small intestine predominantly, but they did a study on this Chinese kid, and they were giving him fecal transplants every 3 months, I think it was. Okay. And they completely reversed his autism through. I mean, they had to continue doing it. Like if they stopped doing the fecal transplants, his autism would come back. But he went from being, completely unable to communicate to just being a completely normal child. It was pretty amazing to see that.
Yeah, and I think that's almost the tip of the iceberg when it comes to microbiome research, and in terms of the excitement level that people have, is because there are case studies of reversal of Alzheimer's disease post FMT. Like there's a couple of published cases of people's Alzheimer's going after FMT, and there's fecal microbial transplant, and there's animal studies showing that again after fecal transplant from healthy mice, for example, like that, the brain actually clears away the sort of damage that was there before, so that you can actually clear away the amyloid plaques, etc., in the brain post FMT. I mean, it's pretty amazing stuff, and I've seen that stuff working with kids on the spectrum, where one just doing microbiome work with prebiotics and dietary change, inducing massive shifts in learning and cognition, speech, etc., to working with people who with ASD who are doing fecal transplants as well, and again seeing sometimes these massive leaps forward that occur post FMT. Yeah, and even I think that the breadth of conditions that we're now associating with, again, colonic dysbiosis or colonic microbiome changes is growing hugely. Like we can transfer high blood pressure from doing poo transplant, and that was not something that was on anybody's radar before. That you could take poo from someone with high blood pressure, give it to rats. You know what? They develop high blood pressure. And we can take, poo from healthy people, give it to people with high blood pressure, and their blood pressure goes down from that. So no other diet change, no other lifestyle change is changing the microbiome. And we've seen similar things with metabolic dysfunction, like, with blood sugar control. I mentioned some stuff with Alzheimer's disease before too. There's some promising research in Parkinson's disease, multiple sclerosis. It is really an area where the research is super exciting in terms of what capacity we have to shift some of these sort of chronic incurable conditions by changing the microbiome. It is really exciting.
Yeah, and that just underlines how important the microbiome is, doesn't it? If you can, transplant microbiome into someone and their health condition is reversed, it really tells us. It's almost like the control center, right? We think of our brain as being a control center, but probably just as much that the gut is probably just as much of a control center as our brain.
Oh, it's absolutely huge, and this is why when there's like dietary approaches or lifestyle things that cause harm to that microbiome, I cringe. I just worry about the repercussions of that because of how important the ecosystem is. And I think if you're making decisions around your health without knowledge about how important the microbiome is, then I think we're actually doing it uninformed way that can lead to harm. And this is what Westerners have done for a long time, is ignore the presence of those microbes. It's starting to not so much now, though I still think it hasn't necessarily gone out to the ground yet in terms of your day-to-day average GP. Doesn't have much microbiome stuff on the radar, but that will change with time. And I think even areas like cancer treatment, that's another area where microbiome stuff is booming too, because they realized that someone's baseline microbiota composition can determine whether they actually respond to this anti-cancer treatment or not. Hugely. Yeah, I think there was like skin cancer, melanoma, and people that had one type of gut ecosystem that was dominated by a species called Bacteroides, which is like really dominant in Western nations. People in the UK, Canada, US, Australia tend to have Bacteroides dominate ecosystems because that they kind of like our Western diet and lifestyle. They tolerate antibiotics pretty well. They like junk food. Like they tend to go really well on a Western diet. But if you've got that ecosystem and you go through this, melanoma treatment, you have very little chance of getting a good outcome. But the patients that had ecosystem dominated by another microbe called Faecalibacterium end up, I think it was 67% of them actually responded really well versus 0 in the Bacteroides dominant ecosystem. That is massive. So there won't be that long before you can't ignore stuff like that for too much longer, because that's life and death situation. People get better or they don't based on microbiome composition. And we can change that by changing their diet, by using the right prebiotics. We can change someone from Bacteroides dominant to Faecalibacterium dominant. In majority of cases within 2 to 4 months or something like that. So it's generally quite a modifiable risk factor that can actually make a big difference in terms of treatment outcomes. So I think research like that is really, again, going to creep out into the community, and eventually patients aren't going to, at least if patients know about it, they're going to start asking about it. And this is what I've seen too, is that oncologists, not that I've come across, actually are aware of this research, but patients are, and they're coming to me going, I've got melanoma, I'm going to go through this treatment protocol. Can you make my microbiome healthier so I have the best chance of getting good outcome? And it's like, yes, we can work and work on that. But eventually that's going to start filtering through, and eventually it's going to be that microbiome assessment before, cancer treatment will become just standard practice.
Very interesting.
Yeah.
Just coming back to SIBO again. So you mentioned the gas being produced by certain bacteria. So, we know that, SIBO might have high amounts of bacteria that produce methane, hydrogen, or hydrogen sulfide.
Yep.
Can you maybe explain what the typical symptoms are experienced with each type of gas produced?
Yeah. I mean, I think we touched a bit about methanes before, so I'll probably hone in there a bit more. I mean, methane's main consequence when you have excess amounts of methane being produced is a slowing of the gut transit time. Okay, so that can manifest in constipation, where you're not pooing every single day, or your poos are really hard and rock-like and really hard to get out. Yeah, but I think on top of that, which can result in hemorrhoids and anal fissures and a backup of gas like bloating and distension occurring because things just you're not pooing, therefore the gas can't get out either. So you're just blowing up like a balloon because of all the gases building up behind that sort of poo backlog. But on top of that, you're also getting absorption of bacterial toxins and other compounds from that bowel. And naturopaths in the past used to call it bowel toxemia. And I think it's a really apt term, even with modern research showing, it's actually true. That's what's going on, is when your bowels aren't moving, you're actually absorbing a whole bunch of different compounds like bacterial endotoxins in much greater amounts. And hence why there's a link between, constipation is a risk factor for Parkinson's disease development, because it's bacterial toxins that are causing the Parkinson's, but it's the absorption through the slow bowel that's the trigger. Yeah, so it's that's more of the extreme end of things. But again, you're getting essentially absorption of those sort of bacterial toxins, endotoxins, I'd say environmental toxins. You're getting a second go at in that situation from high methane. So you will get other body-wide symptoms like brain fog and fatigue and depression alongside argue also slower metabolism too are common sort of consequences of that high methane scenario. Hydrogen gas is interesting because it is much more arguably a bigger, bulkier gas than methane. So you might get much more acute bloating and distension from that. Interesting enough, methane is mostly because it's more condensed, dense gas. It slows down the gut, and that's why it causes bloating and distension, whereas hydrogen is just big and bulky, so you tend to get this very clear, quick reaction of bloating and distension within like 15, 20, 30, 60 minutes of eating. Your tummy goes out. That's very classic hydrogen. Hydrogen sulfide so there's some debate about what classic symptoms are. For me, it's very sulfury burps and very sulfury flatus would be pretty classic symptoms of that, and worsening of symptoms after sulfur-rich foods or after meat as well, because meat is high in sulfur-containing amino acids, or worse after fatty foods too, because of the outflow of bile. The more higher fat intake we have, particularly saturated fat, we get more bile being produced, and there's more sulfur in that bile, which then produces more hydrogen sulfide gas as well. So there might be correlation between, I eat more protein or eat more fat, I get worse symptoms and more, stinky sulfury sort of flatus. That might be pretty classic. In that way, bowel pattern, I could argue, will go either way. I mean, I think some people would suggest that hydrogen sulfide is diarrhea. I don't see that all the time in my patients, although it's probably more common than constipation. But I do have patients who have slow transit time and have high hydrogen sulfide gas as well. But I'd say more commonly associated with more normal sort of transit time when you have high hydrogen sulfide gas being produced.
And then also you have some people that have more than one gas that's high as well, right? Which we generally call mixed, don't we?
Yeah, that's right. And you could argue that for people that have high methane issues in the small bowel, they've also got high hydrogen issues too, because the methane producing microbes eat hydrogen. So they actually need bacteria to produce a lot of hydrogen first for them to make the methane. So we may not see it initially on that test because you'll just see the spike in methane, but we know there's actually hydrogen hiding behind there too. But you're right. In some people, we see this very clear increase in hydrogen and methane on a test, which we call mixed SIBO.
Hmm. Yeah. I guess there are people probably listening to this now and they're thinking, okay, you're talking about symptoms that I have. But I guess the question might be for a lot of people thinking, but why, what are the main reasons why people actually get SIBO? Julie, a 47-year-old who works in computer sales, came to see me complaining of lifelong irritable bowel syndrome, which included severe abdominal pain and bloating, loose and very frequent stools, along with hot flushes, menstrual brain fog, and low energy, which affected her work performance. After taking a comprehensive history, plus running some labs, I discovered that Julie had a parasite infection, which may have been causing the loose stools, a methane-producing bacterial overgrowth that was almost certainly causing the abdominal bloating and pain, a leaky gut, low levels of digestive enzymes, as well as eating too many high oxalate foods on her vegetarian diet. So Julie reduced the high oxalate foods from her diet, plus she took a broad-spectrum antimicrobial supplement to help with the parasites and the bacteria in her gut, probiotics to increase her good bacteria and help repair her gut lining. She also took prebiotics to help feed the commensal bacteria, digestive enzymes to improve her digestion, and herbs to help clear the toxic lipopolysaccharides from her system produced by the overgrowth of gram-negative bacteria. At the end of the program, Julie reported that her health had never been better. In her own words, the improvement is staggering. The abdominal pain and bloating was gone. Her stools were back to normal. Her energy was up. She no longer had brain fog or hot flashes, and her immune system had improved as she no longer suffered from frequent bugs and colds. If you're suffering like Julie was and you want to get to the root cause of your problem, you can arrange a consultation with me at bodycheck.co.uk. That's BODYCHEK. And if we're a good fit, I could help you achieve the same kind of results as Julie. Now, back to the podcast.
Yeah, I mean, I think there are certain things we know are risk factors. I mean, I can say from my clinical practice, the most common risk factors are food poisoning, traveler's diarrhea type events, where we have this sort of initiating event that has essentially created some degree of inflammation and dysmotility. So your like normal motility has been altered by that infectious event, and that hasn't normalized, and that allows, rather than these lovely cleansing waves moving into your small bowel to move food and bacterial through, they're not happening so much, or it's a disaltered or disorganized movement, so it doesn't actually push stuff through, and that allows bacteria to build up, and then boom, you have SIBO. So that's a pretty common driver. I also see binge drinking alcohol as a common driver of SIBO. opiate medication use, things that, again, that slow the gut down. Alcohol does that too. Alcohol acutely slows down movement in the small bowel. Also alcohol in larger quantities is a selective antimicrobial that kills good bacteria and leaves more gram-negative bugs like E. coli alone. So you end up with that sort of double whammy of slowed motility and increased levels of bad bacteria from alcohol ingestion. So that's often a driver too. And there are certain disease conditions like type 2 diabetes or chronic pancreatitis that we would associate with increased risk of SIBO development, rheumatoid arthritis, acne, rosacea as well is one of the other conditions that seems to be associated with greater risk of SIBO. Too, sometimes it's like the SIBO causes things, like I think SIBO is a driver of acne rosacea, for example. But other times, like in type 2 diabetes, if you have motility issues due to nerve dysfunction due to high blood sugar control, the diabetes is actually causing the SIBO. Celiac disease, Crohn's disease have higher risk of SIBO development too.
Yeah, and there's also like physical blockages as well, isn't there? It's a known cause of SIBO as well.
Yeah. I mean, sometimes you have it in, I've had patients who've had abdominal surgery where they've had bits of their small bowel or bits of their colon removed, and yes, that those are high risk factors too. And some would also point out that if you have had previous abdominal surgery, you can get scar tissue that builds up, and the scar tissue can impact motility and then result in SIBO too.
Yeah, very interesting. So I've got quite a big question for you now.
Yeah.
And I know there's a lot of let's say different views about what I'm going to ask. So I'm talking about testing for SIBO.
Yep.
What would you recommend as being the gold standard if say a client came to see me and they had no budgetary constraints? What would you suggest would be perhaps the gold standard for testing for SIBO?
Yeah, good question. And I can say my views on testing have developed from one, reading through lots of research over the years, and two, my clinical experience I'm testing hundreds of patients. Yeah. So that's altered things too, based on what I've seen in terms of clinical reality. To me, the optimal testing protocol for SIBO is doing triple breath testing. So it's not just doing one sugar, it's actually doing three at different time points too. You can't just do all three sugars at once. That won't work. So I recommend you do glucose, you do fructose, and you do lactulose. Okay. And this differs a bit because in the States, they're very much into lactulose alone, and very few practitioners do anything besides that. In Europe, the research and I'd say the research consistently shows that glucose has better diagnostic accuracy than lactulose. But I think that, again, from doing lots of breath testing, glucose can miss certain cases, and I know lactulose definitely misses cases too. But what I found from doing, again, just breath testing on hundreds of patients is that fructose is really important, and it would often pick up SIBO that was missed by glucose, and if you just did lactulose as well. Yeah, and this is something, again, that evolved for me. I just started doing, at the very beginning when I tested SIBO, I always did glucose and lactulose because that's what the literature, in Europe, they said use glucose, and States have said lactulose. I'm like, okay, well, I'm going to do both because, I want to see with my own eyes which ones tend to work more accurately with patients. I'm aware of the research and the limitations of both those sugars. So that it's, combine them essentially and try to minimize the weak areas. But then I started doing fructose for patients that were, reacting to apples or pears or mangoes or watermelon, and what I worked out is that the vast majority of patients who were reacting to fructose actually were having small bowel fermentation of the fructose. Okay. And this is something that's interesting because it wasn't talked about much at all. I lecture on fructose intolerance, and all the papers on fructose intolerance that were out there all talk about you malabsorb fructose in the small bowel, it reaches your colon, and then you get the spike of gas. Okay. I was not seeing that in my paper. I was seeing all these people with this spike of gas of that hydrogen gas or methane at the 20-minute mark, 40-minute mark, 60 minutes. It's not in the colon. Then it's in the small bowel. And you treat these people for SIBO, and their symptoms go, and they can eat apples and pears and all these things again. Yet with the classic idea of fructose intolerance, it's a lifelong low fructose intake is how they manage it. Not that it's curable, but it turns out actually it is curable when it's SIBO induced. fructose intolerance. So again, and then I started doing this triple sugar testing on everybody, and then I realized that actually the fructose gave me I would actually argue, the best results. And we did this, just sort of in clinic scenario where we just took 130 consecutive patients we suspected of SIBO. We did triple breath testing, sugars on. So they did glucose one day, then they did fructose the next day, and then lactose the next day. And we kind of looked at the results and said, okay, how accurate were they for finding the SIBO? And I think lactose alone picked up SIBO 73% of the time, or methane issues, small intestinal bacterial overgrowth or methane issues, 70% of the time. Glucose alone was 67% of the time, but fructose alone was 85% of the time. So I actually had better pickup value with just the fructose. But if I did, if I combined this lactulose and fructose, 96.5% of what we worked at were picked up. We chose those two. And if I use glucose, and we get an extra 3.5% on top of that. So with some patients where money is more of an issue, I will just use lactulose and fructose, because I think that's, 96.5 is pretty good rate of picking it up. But if money's no issue, and you really want to make sure, because there was 3 out of 100 people where glucose would pick it up and the other sugars did not, so I think it's really important to actually make sure we do multiple sugars. And there's a good reason for this too, because we know that lactulose is a selectively fermented sugar. So not all bacteria, particularly not all bugs we know that are there in SIBO, can actually eat lactulose. So of course it's not going to pick it up. If that you have bugs in your small bowel in excess amounts, you cannot eat lactulose. You're not going to pick it up, but they do eat fructose and they do eat glucose. All right. But the issue with glucose is it's really well absorbed. Our body's really apt at grabbing the glucose. So glucose is great for picking up the SIBO in the first bit of your small bowel, where the glucose is. But it's not good at picking up SIBO in the middle or last bit of your small bowel. Whereas fructose is eaten by all the different bacteria, like glucose, but it is very slowly absorbed. Yeah, it's like this facilitated active diffusion, I think, is the technical term for absorption of fructose. So it's very slow, which means that the fructose actually reaches the middle bit of the small bowel and the last bit of the small bowel, which is why I think it actually works so well to pick up SIBO, or cases where glucose misses it, and lactulose, because lactulose, again, only some bacteria can eat it and some don't. Glucose, everything eats, but it's not there in the distal and middle small bowel, whereas fructose hits both those criteria. And I think that's why it's more accurate for picking it up, in my experience.
Yeah, and that's really great information to know. Because when I initially did my training, it was just one substrate that you used to test for SIBO, and then obviously when I took your course, it was like, well, that makes complete sense. You're getting a much bigger picture.
Yeah, and the number of cases of SIBO I would miss if I just chose lactulose is huge. It really is, because I do that triple sugar or double sugar testing. It's like, oh, if I just chose lactose, I miss it. It shows up so frequently in my patient cohort. So I'm glad that I don't. I think we're kind of doing our patients a disservice if we're only doing the one sugar. I think that's the reality of it. There's a decent chance we're going to miss what's there.
Yeah. And what about stool testing?
That's a big question. Why are you more prompting around that one?
Well, I mean, obviously, one of the things that, these bacteria, obviously they live in the small and the large intestine. So, you could test for small intestinal bacterial overgrowth, but the problem could potentially still be in the large intestine, right?
Yeah. And I would say for the majority of my patients, I also do a colonic microbiome assessment via the stool too.
Yeah.
But we know that we can't diagnose SIBO based on a stool test. We can't. I think there are occasions where you might get a clue as to what microbes might be overgrowing in the small bowel. If you do the breath testing that's positive for SIBO, and you get the stool testing, like, oh my God, they're really high Klebsiella, or they're really high Escherichia, or they're very high Streptococci, well and truly above normal levels, you might go, okay, I reckon it's likely that you're a Klebsiella SIBO person, or a Streptococcus, and then we might be able to tailor treatment more effectively. But we couldn't just go, oh, you're high Klebsiella, therefore that you must have SIBO. No, because those things are generally, we would say are growing in the large intestine. But I'm quite willing to run with the idea that if they got definitive SIBO and they have really high levels in the stool of bugs we know cause SIBO, like Klebsiella, Escherichia, Streptococcus, then I can target my treatment more effectively, and I think it works better because I can go, okay, well, I reckon it's Klebsiella. Let's choose my herbs that are better at targeting Klebsiella, for example.
Yeah. Yeah. So I guess the reason I asked that was the original question was, what would be the gold standard? So the gold standard would be to test all three different substrates for the small intestine, but also to test the large intestine with stool as well.
I think in terms of arguably getting the best results for patients, yes, and discerning, because you don't necessarily know what the result's going to be. And it's going to be positive or negative until you do the test result. So often when I'm seeing a patient for the first time, I'm like, I want to look at your colonic ecosystem too, because it may need, I suspect SIBO, but it might not be the case. And this might be something going on in the colon. And if I wait till those results come in and go, okay, well, they're fine, let's do another test to look at your microbiome, we're kind of delaying finding answers. So I'm often at that first consult going, okay, let's test your microbiome. Let's do the breath testing if I suspect SIBO, so we can get some answers. And then I might do other tests too, depending on what the presentation is. But I think it can help fill in the gaps, because you might go, okay, again, there might be high levels of hydrogen sulfide gas producers on that stool test. There might be a bunch of other imbalances that we know are going to cause harm to this patient, either in the short term or now or the long term, that will show up on the stool test. And because just the vital importance of the gut microbiome is like, we want to know that data. Like, I think it's key if we want to gauge our patient's health status, we need to look at the microbiome.
Yeah, absolutely. So with regards to overcoming SIBO, now, of course, we need to treat every case on an individual basis. We need to look at, the client history as well as the tests, etc. But what factors do people need to take into consideration, and what available kind of protocols do you generally recommend?
Yeah, and this is an area of controversy or ongoing discussion or debate about, particularly around from a dietary perspective, because there are some clinicians who put their SIBO patients on really restricted diets, and that can be carnivore as the one extreme end of that, and there are others that are just like a low FODMAP or a SCD diet, specific carbohydrate diet, or biphasic diet, which are more restrictive dietary approaches. And then, like myself, I actually don't think that. I think dietary restrictions can limit symptoms, but I don't think they actually fix the issue. Yeah, like I've had patients who have gone low FODMAP or SCD for months or years, and they eat an onion or a garlic or some legumes, and that half an hour later the symptoms are there again. So it's like it hasn't got rid of the bacteria. It limits the symptoms that they're experiencing day to day, and that's not necessarily a bad thing, but it doesn't fix it. To me, really restricted diets lead to colonic issues, colonic microbiome issues, for example, that I have concerns about. So I don't think they're necessary. So I try to minimize the sort of dietary restrictions as much as I can. And I might go, okay, well, let's do low FODMAP and let's avoid any foods that are known triggers. Let's avoid alcohol. Let's do some, lack of snacking, because we know that snacking, if you're constantly putting food in, we kind of can impact our motility negatively, which can allow bacteria members to sort of grow up. So there are some tweaks we can do around there, but I'm not someone that does like really, really restrictive dietary protocols. And part of that's because I think, one, I had that experience where it doesn't cure anything, it just limits symptoms. And two, we know that bacteria like Klebsiella, like E. coli, like Bacteroides or Enterobacter that we find in SIBO studies that show up in people's guts with SIBO, eat amino acids and protein. So even if you just go, I'm just going to eat meat, it's like you'll get less gas. Totally, we'll get less gas from that, less hydrogen gas. You make, I think, 1/3 the gas sort of fermentation level when the microbes are eating protein amino acids versus carbohydrates or fiber. A lot less gas, but you're not starving them. They're still eating. They're still happily growing. It's just you're getting less symptoms from that. So I think it's really important that we separate that out. And two, also knowing that, okay, well, they're making less hydrogen gas, the Klebsiella and E. coli, we're making more hydrogen sulfide gas if we give them more sulfur-rich amino acids to consume. So it might cause less bloating and distension, but it might cause more gut inflammation as a long-term result of that. So hence, I've always had concerns about more restricted diets for SIBO. And to me, it's like the herbal medicines, it's the probiotics and the prebiotics that do the heavy lifting. They treat the overgrowth. They can help us improve motility. They can help decrease the inflammation that's led to the dysmotility. For example, those tools I think are doing the heavy lifting. The diet is mostly around how do we make your life comfortable while the other things are working.
Mm. And what about things like antibiotics, both kind of pharmaceutical and herbal?
Yeah, I mean, I'm a naturopath herbalist, so I use herbs to treat, and I don't generally use antibiotics. I know like naturopaths in the States, often they're trained to prescribe antibiotics. They will do so at a much higher rate than what I ever would. But if you look at the data around the most common antibiotic for SIBO is rifaximin. Rifaximin, again, the studies on it are I'd say mixed quality. I would say that, I'd say they're generally poor quality is when they've done a review, they pull all the data together. There was like evidence of their poor quality studies in general. There was evidence of what they call publication bias, which means that they only published the positive studies and they didn't publish the negative studies. And there was, a lot of them are open label studies where there's no placebo, so you can't necessarily say, okay, your symptoms are better because of the antibiotic. Could have been placebo effect as well. And even within all those constraints, I think that maybe it worked in like 70% of people. Yeah, and 30% of people didn't get any sort of improvement from that. And just with some comparative context there, probiotics, a systematic review looking at giving probiotics to people with IBS, to SIBO patients, definitive SIBO patients, was like 54% eradication rate with just giving a probiotic. Yeah. General, that's combining all of that together. So,
and is there specific strains that tended to work?
Well, yes. I think in real life there is, but I think in this study they just pulled all the data together. So they kind of include, we can't see those specific details. But when you start looking at the individual studies that were included, like there was a study published just a couple months back where they had patients with liver cirrhosis with SIBO. All right, and SIBO is like liver cirrhosis is very like end stage sort of liver damage. It's going very poorly. And SIBO is a driver of liver dysfunction due to its release of endotoxins. The endotoxins cause liver damage. Yeah. And that's built up over time when you get liver cirrhosis. So these patients had, cirrhosis of the liver and they had SIBO, and they gave them, placebo, or they gave them, in this case, Saccharomyces probiotics. So Saccharomyces cerevisiae, Variety boulardii, CN-CM I745, if you want to know the exact details. It's the original, Saccharomyces boulardii, essentially. And I think there was 80% cure rate in 3 months. The SIBO was gone in 80% of people in 3 months of taking the probiotic. So you have studies like that. There's like, you'd see these definite improvements that are there. And yes, I think there's other probiotics that can prevent SIBO from developing. So one other common cause of SIBO we didn't talk about before is proton pump inhibitors, so those sort of reflux medications. I read a study just a few weeks back that they gave PPIs to healthy people, and 8% of them developed SIBO in 1 week on the PPI.
Wow.
Yeah. 8%. And the authors were like, that's not bad. It's just 8% of people developing SIBO, we can keep using them. And I'm like, that's after 1 week. And it isn't like I treat lots of people with SIBO. Some people, it's just one course of herbs and it's for a few weeks and they're great. And other people, it's not. It's like a bloody long thing. It takes a lot of work, a lot of time, a lot of money to treat. So I think 8% is quite a bit, personally, for 1 week's sake of one medication. But there's other studies showing that maybe it's like 50, 60% of people after 12 weeks of taking PPIs. Yeah. So that's a common driver. And so many people take PPIs. They're like, reflux medications are huge, both over the counter and prescribed in Western nations. And they take them daily for years, and they're basically inducing SIBO in all these patients. But it's a bit of a side point. But there was one study where they gave a probiotic alongside the PPI, and this one was Lactobacillus reuteri DSM 17938. Okay, and that's sold around the world as BioGaia. And that reduced the incidence of SIBO development in kids taking a proton pump inhibitor. It went from 56% in placebo to 6% which is a massive difference in terms of whether SIBO developed or not. And we know that particular strain can also produce methane levels in the gut too. There's other studies of people that are producing excess methane, and that strain decreases its methane output. It also tends to soften the stool and speed up transit time and increase stool frequency. So it can work well in that sort of methane slow transit time picture. So it's kind of my strain of choice. And likely it's because that particular strain produces, at least in part, a substance called reuterin. And reuterin is like a selectively acting antimicrobial compound. And other bacteria that have been tested in similar models don't prevent SIBO developing with PPI use. There's something specific about that strain. So we can't just go, any probiotic will be fine, because I think that's definitely not the case. But we know that some are particularly helpful for SIBO prevention or SIBO treatment.
Yeah, that's really interesting. And just going back to the antibiotic side of it, particularly the herbal side, what's your view on using herbs for SIBO?
They're my core treatment. So, and I think even amongst, like, I use the probiotics, I'll use a prebiotic like partially hydrolyzed guar gum, which we know can help reduce methane load in people that have high methane. We also know that it enhances the efficacy of antimicrobials. Like, there's a study where they gave partially hydrolyzed guar gum, I'll just say PHGG from this point, where they gave it alongside rifaximin, I think with placebo, competed with SIBO. And I think it was a 62% eradication rate with just rifaximin versus 87% with the partially hydrolyzed guar gum. So I was like, okay, well, I'm going to use PHGG alongside my herbal antimicrobials to try to improve the sort of efficacy rate of treatment, even in my hydrogen dominant SIBO, and definitely mixed SIBO, and definitely in methane issues too, because it's got that direct anti-methane activity. But yeah, the herbs are still doing the heavy lifting, and for me, there's a number of herbs I will use, and that, the ones that I use commonly are ones like pomegranate husk, and garlic, and I think particularly an allicin-rich garlic extract. I want to be more specific here. Pomegranate husk is the skin of the pomegranate fruit, and it's been used in Ayurvedic medicine for 2,000 years to treat gut infections and diarrhea. Traditional Chinese medicine for 1,800 years for gut infections and diarrhea, and Western herbalists have been using it for a long time. It's kind of fallen off the radar a bit up until more recently, but there's a lot of research on it. It's very good at killing E. coli and Klebsiella and Citrobacter and pathogenic bacteria. It's very good at, but it leaves our good guys intact. And to me, because my PhD was in essentially the wonders of the microbiome, it's always been imperative to me that how can we selectively modify that? And that was like my whole PhD journey was, okay, well, how do we selectively modify this ecosystem? Not just kill everything. How do we just get rid of the bad things and leave the good guys alone, or encourage them? Yeah. And that even led me to do research on what impact herbs might have on our good bacteria, and which herbs might harm our good bacteria. Yeah, as part of my PhD too, because that was all involved with that. So even when I'm choosing herbs, I know that some herbs can harm our good bacteria. Things like berberine and berberine-containing herbs can definitely kill our bifidobacteria, can definitely reduce levels of diversity and butyrate-producing microbes in the gut, particularly with longer-term use. Berberine is quite problematic from a microbiome perspective, where you have other things like pomegranate husk, which is selective and actually has been found to encourage the growth of bifidobacteria, encourage the growth of butyrate-producing species, but actually also target effectively bugs like E. coli and Klebsiella, for example. But I'll generally use a combination of herbs to try to get better results as well. But those two, I think, are key. Because garlic, again, is selectively acting, to at least the doses we typically would use. That you took like half a bottle, yeah, sure, you're going to get some die-off bifidobacteria too. The doses we tend to use to treat SIBO, bifidobacteria are fine, beta-producers are fine, but we do target bugs that we don't want so much.
And what about oil of oregano?
Similarly, that it's research I did as part of my PhD was oregano oil, oregano oil, depending on what country you're from, was very good at killing bifidobacteria. Yeah, and so I don't use essential oils in my treatment of SIBO, except in very rare circumstances. But I will use tinctures. Yeah, so I will use oregano tea. Totally, I will use oregano tincture. Yes, but I won't use the essential oil because I don't see the collateral damage with the tincture and the herbal tea. Yeah, the tincture is more effective than the herbal tea. And they will work a bit more slowly than the essential oil. I agree. but you don't get the collateral damage. And I think this is key, is that, again, the more we research about the importance of the microbiome, the more we want to avoid agents, whether they be natural or synthetic, pharmaceutical, that cause harm to that ecosystem when we can. And there's obviously times where we can't, where life-threatening infection, your arm or something. Yeah, you take whatever antibiotics you're prescribed to deal with that infection. We try to fix the consequence. But if we have a choice between berberine, which is going to cause, or oregano essential oil, which is going to cause collateral damage, or a herbal preparation that won't, why would I not choose the one that doesn't? For the majority of patients. And maybe I'll have the berberine and essential oil as my big bazooka cannon to pull out from patients who don't respond to the first sort of 4 levels of the treatment. But I'm certainly not going to use it initially before using things that are likely to work but not likely to cause microbiome harm.
Yeah, that makes complete sense. So we've looked at the microbes. What about potentially speeding up motility? Is there anything that you would do for that?
Yeah, and that is an essential thing that as part of treatment, particularly post-treatment, if you want to prevent SIBO from redeveloping, because it does have a tendency to redevelop. Sometimes when patients have, had the misfortune of being food poisoned again, or in another case, of traveler's diarrhea, boom, particularly in the first 12 months after SIBO, it will often come back. Antibiotics after a course of SIBO, in the first 12 months after SIBO, will often bring back SIBO, and alcohol binge drinking too, just while I'm on that tangent, will often are factors that essentially drive a regrowth of SIBO. But beyond those things, one of the things we think about is maintaining that motility. We want things to be moving both through the colon, but also through the small bowel. So we're often be using prokinetic agents. So, medical clinicians will prescribe, like low-dose erythromycin or something, or percolopride to try to get things going, whereas naturopaths might use things like a barogast, which is a herbal preparation that it can improve motility. We might use ginger to do so, or 5-HTP, or magnolia bark is another herb that's traditionally used in Chinese medicine that's got some good data on it for improving motility and improving the functionality of your intestinal cells, called the interstitial cells of Cajal. And magnolia bark helps them function better. Which is pretty cool. And it's been used for 1,000 years to treat bloating and distension and food stagnation in the gut, which is pretty classic sort of SIBO picture right there.
Yeah. So we've looked at dealing with the microbes, improving the speed of motility. I guess the other thing is inflammation.
Yeah. To me, it is. And the inflammation is often what's driven the dysmotility too. Yeah, so I think when we're trying to fix the dysmotility so their functionality will become normal, and then that will prevent SIBO from redeveloping, we need to work on that inflammation that can be caused by the food poisoning, caused by antibiotics. Antibiotics actually cause gut inflammation when we ingest them. For the most part, there's the exceptions like rifaximin, but most of them cause increased inflammation in the gut. So using herbs, like for me, a well-absorbed turmeric extract is key. Here, one Mariva phosphatidylcholine extract works really well, but other well-absorbed turmeric ones will be applicable too. Boswellia are two that I use widely. But even things that enhance butyrate production in the gut will have a sort of healing anti-inflammatory effect as well. So we're working on, partially hydrolyzed guargum, that prebiotic compound we mentioned before, feeds butyrate producing species, which increases butyrate production and therefore has a healing effect, not only in the colon, but also in the small intestine too. So we're also focusing on nurturing those sort of anti-inflammatory gut species in the gut and enhancing butyrate production too.
Yeah. And I guess the other thing we possibly haven't discussed yet, obviously we spoke before about one of the causes being blockages. Obviously there are specific treatments that can be used to help with blockages too, right?
Yeah, I think going back to I mentioned before around sometimes people have adhesions and scar tissue, and I think that in those situations it's often about seeing an osteopath or physiotherapist who's adept at actually doing visceral manipulation and help loosen things up. And I've had some patients where that's made a big difference to their recurrence rate of a SIBO. Yeah, we could effectively treat it fine, but then it will come back because you've got these adhesions and scar tissue that's stopping motility from happening. So it's important to sort of loosen those things up to allow that greater movement and flow.
Yeah, I'm familiar with the Burrell Institute. I don't know if you're familiar with the Burrell Institute, but they teach people in visceral manipulation.
Yes.
And yeah, they're in many countries in the world. I actually know someone in Sydney that does visceral manipulation, trained by the Brown Institute. So they're the people I generally look for to refer to if someone has that kind of condition.
Yep.
Awesome. Jason, this has been absolutely fascinating for me. It's been really enjoyable. What's next for you? What have you got lined up next?
At the moment, I'm really enjoying teaching my own courses. So I teach health professionals in my sort of educational center, which is called the Microbiome Restoration Center. And we do 2 10-week courses a year. One is on sort of naturopathic and functional medicine approaches to gastrointestinal conditions, which we cover, IBS and SIBO and a bunch of others in great detail. And we do a second course on advanced microbiome manipulation, which is just like 10 weeks of just microbiome madness, which is great. So that's my passion at this juncture of time. And we've just started. We're like week 1 and week 2 into my functional gastroenterology course right now, and then my microbiome one starts in October. Yeah, so I'm thoroughly enjoying that, and it just means I could get an excuse to keep up to date and keep reading all these amazing papers, and then trying to implement those things with my patients, and then using that as feedback from the people I teach, because I think that's the beautiful thing is like there's research, but then what works in real life. And some things that work in studies don't work in real life, and some things work beautifully in real life, and you want to like shout it from the rooftop to get every clinician to use it because it's such an amazing scenario, amazing tool.
Yeah. Yeah, and there will be practitioners listening to this podcast. I highly recommend your courses, having done one of them myself. Certainly helped me a lot in my own practice, helping people with gut issues. So, yeah, highly recommended. So, where can people find your details online, Jason?
Yeah, well, there's the Microbiome Restoration Center that I mentioned before, and also the Probiotic Advisor is the other place where I essentially have a evidence-based probiotic database, which we keep updated with probiotic research to go, so you can know which probiotic is best to treat what condition, because that's huge area we didn't touch on today at all, but you could do hours and hours of discussions around probiotics for different things. And I think it's really about how do we get the best outcomes for our patients is using the clinical evidence showing that this strain is good for this task, this strain is good for that task, so we can actually choose the best tools for our patients. So there as well.
Yeah. And are you on social media?
Very rarely. I do a Facebook page, and I should engage more. But to be honest, I find more enjoyment in actually reading papers, teaching, and seeing patients, and posting on Facebook or Instagram. So I'm a bit slack in those areas. But I do have a Probiotic Advisor Facebook page for sure.
Great. Jason, thank you so much for your time. I've really enjoyed it. I love nerding out on information, particularly on the microbiome. And also, I'm sure there's going to be people listening to this episode that are going through, SIBO type symptoms, and that, they're probably going to get a lot out of this as well. So, just thank you so much for your time.
You're very welcome, Lee. As you can tell, I enjoyed nerding out with you. It's all good.
Awesome. So that's all from Jason and me for this week. But don't forget, you can join me same time, same place next week on the Radical Health Rebel podcast. Thanks for tuning in. Remember to give the show a rating and a review, and I'll see you next time.